everybody, and welcome to episode 21 of Blood Matters, a podcast for nurses. We have an absolutely fantastic episode for you all today. We're going to talk about adult fertility preservation. I think this is a topic that many of us touch on in practice. Often happens at a time when we don't have a great deal of time to be able to plan and proceed. So we want to bring this up as an episode for the pod. And we are very, very fortunate today to be joined by Iebe. Quick. I'm also joined by my original co-host, Emma Chalmers. And it's been a while, I think, since we recorded an episode together, Emma.
Yes, yeah. Just with us also having Hilda, which is a great wee team. I can't believe you just said 21. We're
Yeah,
at
yeah,
episode 21. How cool.
yeah.
But yeah, morning, guys. Thanks for joining us.
Excellent. And I'd like to bring in our guest, Iebe Quick. Iebe, do you want to tell us a bit about yourself and what you do?
Yes, thank you, Michelle. Good morning, everybody. Thank you for listening. And my name is Iebe. I'm a nurse, midwife. I work in a university hospital in Brussels, and there I am in charge of the nurse-led fertility preservation program of our fertility center.
That's fantastic. Thanks so much, Iebe. And really are very lucky to have you here today. You really are a true expert. And I hope through the conversation, we're going to be able to kind of bring out some of your expertise and also share a little bit about the experiences that we have and some of those things that make us feel a little bit uncomfortable, I think, about fertility preservation because of the sort of the implications and the nature of what it is that we're doing when we're having those conversations with patients. So I think we're going to start by trying to kind of bust a common myth around
Mhm.
fertility cryopreservation, and I think you have brought something to the pod that you feel is really relevant. So go
Yes.
for it.
And what we often see when people come to us for fertility preservation, the biggest myth that we experience is that it always leads to a successful pregnancy.
Mhm.
So when you cryopreserve oocytes, sperm cells, tissue, patients often think, and also oncologists or hematologists, they think that it should lead or it will lead to a successful pregnancy. Unfortunately, that's not always the case. So we cannot always guarantee that it will lead to a pregnancy. It definitely increases your chances for successful pregnancy if you cryopreserve oocytes or tissue or sperm cells. And it also can guarantee a pregnancy in the future, but we see that it sometimes or often we see that it's really hard, especially in hematological patients, to become pregnant after the therapy that they receive.
Yeah, it's really difficult, isn't it? I think, and Emma, I know you're going to share something. We kind of, when we're talking to our patients about fertility cryopreservation, I think particularly those patients that are receiving a new diagnosis of a
Yeah.
hematological malignancy that will have implications on their gonadal function later on.
Mhm.
We're not necessarily thinking about the moments after cure when I mean it's I guess in the conversations that we have sometimes it's just implied but it's not necessarily very much
Yeah.
stated
Mhm.
so I think it's a really important point, and of course I think that perhaps it's not necessary for the hematology and transplant team to be owning all of that discussion.
Aye,
Um,
absolutely not. No.
No,
but
exactly.
making sure that all patients are referred for a fertility consultation. If
Or
this
at
is,
least to get sorry that I'm interrupting you, but
yeah,
at least to get the information, even if they don't
Yeah.
have like an interest in becoming pregnant or
yeah,
fulfill the wish to have children in the future, but just the conversation, are informed that there are possibilities that they can do something, even that they don't have to use it in the future, but just to be informed, that's very important.
yeah. Emma, did you have something to to
Yeah,
add?
just I was thinking about these conversations that we know sort of occur at that beginning of something like particularly a new acute leukemia where the patient is sort of immediately admitted.
Mhm.
And I don't know if it's a bit of a discomfort in the health professional wanting to not also give them more potentially bad news and impactful news. We've just told you you've got leukemia and you've got to go through
Yeah.
quite a lot of treatment. And by the way, this could have a really big effect on your fertility. I wonder if there's a bit of shyness around that. And certainly that's something that I see. I mean, like you say, the success rates, it's not a perfect science, is it? It relies on the body being able to do the bit
Mhm.
later. But yeah, it's
What
a really good
we
myth to bring, Iebe.
Mhm.
Yeah.
What we often see in our center, for example, excuse me, in those leukemia patients, here in our center, we have several options. We also have the IVM option, in which we can perform a punction, a retrieval of the oocytes, and then we can mature them in our lab, 30 hours in the lab, and then they are mature. We see that this is a big step forward in fertility preservation, because we can schedule it if the patient is referred before noon to our center. In the afternoon or the day after, we can already perform the IVM. There are some indications that we need to fulfill, but next to that, it's a beautiful way of preserving the fertility of the patient. And also, if they had already some chemotherapy, we can also still cryopreserve ovarian tissue. That's no
Yeah,
problem, because if they have the state of a complete remission, in that point it should be safe to cryopreserve the ovarian tissue as well. And next to that, we also have the golden standard, the normal hormonal stimulation with the oocyte retrieval after 10 to 12 days. That's the golden standard. And in male patients, we see that the sperm
Can I ask you a question,
collection.
Eva, just very quickly? So for
Yes.
the oocyte cryopreservation, just in case it's not quite clear, and the ovarian tissue cryo, those don't require the hormonal stimulation, the ovarian stimulation.
The IVM doesn't require the hormonal
Okay,
stimulation, and the tissue cryopreservation also doesn't require
doesn't.
any
So they
stimulation.
can be done as soon as it's
Yeah,
feasibly
yeah,
possible to
yeah,
arrange for those
yes.
to be done.
As soon
And
as
do
the
you require
hematologist
also,
says that it's okay, we can perform it. We can
yeah,
schedule everything, and then we can perform it really quickly.
and do you require also a normal platelet count for both of those to be able to be done?
In
Do
the
we need to
platelet
support with
count,
platelets?
if the platelet count is lower than 50,000, then we go to platelet transfusion.
All right,
Transfusion.
fine.
Then we can perform everything. Then it's
So
fine
just
for.
so that's the same as doing any other procedure in
Yeah,
these
procedure,
procedures. It's
yeah,
just like a
exactly.
even a dental
Yeah.
extraction. It's the
yeah.
same.
Mhm.
It's the same. That's amazing. And sorry, you were going to go on and just give us a bit of an insight about the males as well.
The males. So in the males, we have the golden standard, which is the sperm cryopreservation. If we see after the donation of 2 samples that it's not sufficient, we can also go further to a surgical intervention, which is a TESE. So then we can, by taking a biopsy of the testicle, we can perform also a sperm cell cryopreservation. And in the little boys, we can perform testicular tissue cryopreservation, but then they cannot be in the puberty yet. They still need to be a minor, without a puberty, without ejaculations. Voilà.
Thanks so much. You talked a little bit earlier on about kind of having those conversations at the bedside is really so important in order to prepare the patients. Can
Mhm.
you talk a little bit about some of the other things that we can do as nurses at the
Mhm.
bedside?
I think what you already said, maybe it's a bit the shyness of introducing the theme of the fertility preservation, but I think the clear communication, be open to the patient, be honest to the patient. If it is the case that they will lose their fertility and you know it, you need to tell them, I think, because what I see a lot in our clinic is that the patients come and at that point they are not informed at all that they will lose their fertility, and it's really not a nice message to give them when they have already had the bad news, and then this comes as an extra. It can be quite hard for the patient. Maybe also being proactive in your timing. If you expect that somebody will have a leukemia or will have a Hodgkin, refer them already, send them already to the fertility preservation unit to have the information, or at least let them know, so that they can prepare, that the patient will come. And also being able to communicate in the multidisciplinary care of the oncofertility patients. What we see a lot is that they refer the patient, and then we work together. A nice example of this is, for example, when we perform the oocyte retrieval, we also put in place the catheter already. So when they are in a sedation, then it's two in one intervention. So that's really nice. And next to that, maybe also be informed about the options of fertility preservation, because this is an evolving part of the reproductive medicine. It goes on and on and on, and all times there are coming new types of treatment, new types of stimulations, new types of preservation. So that could be also very interesting. And what I told you earlier on, also always ask the patient if they have a desire to have children, if they are at a reproductive age. Even if they don't have it, just refer them for info to us, and then it should be fine, I think.
Yeah, I feel like that assumption that someone's not going to want to have children needs to, it's they still need that info, don't they? Because we don't know what they might decide post-treatment. They might say, right now, I'm not having children ever, and then 10
Mhm.
years time are very keen to have children. So I think that's a really
That's
good point.
difficult, and most of the time it's difficult in very young patients, or
Yeah,
the
yeah.
IAs, like we call them. There we see a lot of times when they come to my consultation, I don't want to have children, but afterwards they are so happy that they did it. So you should advise it.
Yeah.
That makes total sense.
And the evidence suggests that it's the ayahs and the younger adults that have it for which infertility has the greatest impact, right? So
Mhm. Yes.
even more important, I think, for those people to be able to have a very skilled conversation with an expert, I think,
Mhm.
um, I th-
Exactly.
for that. Do you want to talk a little bit more about the psychological impact, Iebe?
Yeah, what we see a lot in oncofertility patients, all types of patients, so not only the hematological patients, is that when we see that they have like a ovarian or testicular failure after their therapy, it's quite hard psychologically and also emotionally. For many patients, it's like closely tied to their identity, to their
Mm,
femininity or masculinity, and also the future life plans, because cancer never comes in a good time, or a disease never comes in a good time. But especially in the reproductive age, you're mostly still at the beginning of your life. Sometimes you maybe don't think about, do I want to have children? Do I don't want to have children? So this points out to, yeah, now you should consider if you want to have children. And I know that it can be what I see in our daily practice, that it's really hard for patients. And also when you get the treatment, when you get the diagnosis, you lose control over your own body. It's another expert that
yeah.
tells you what you have to do, at what time you have to do it. Also in fertility preservation, for example, in hormonal stimulation, we tell them, now you should inject this, now you should inject that, and then you'd have to come for a blood sample and an ultrasound. So that's what I experience in my daily practice.
And
Yeah.
can oh, look we both want to talk, don't we, Michelle?
Yeah, yeah. Yeah, well, I was just going to say, because I think on the hematology ward and the transplant unit, we don't take part in a lot of this in an active
Mhm.
No.
way. It's
Yeah.
it's there's a bit of a dark art, isn't there, around fertility cryopreservation, which I hope that, discussing it in the pod today is going to be able to be very helpful for people, and we'll
Mhm.
signpost to some resources a little bit later on in the conversation. Emma, sorry.
No, I was kind of just thinking more. So we were still talking about psychological impact and emotional impact, and obviously we're talking about that kind of fertility loss thoughts probably prior to the rest of their treatment. But what about for patients who have had all their treatment and they go
Mhm.
through what, we end up a lot of it's sort of locally called perimenopause, or men we put them into menopause, but it's primary ovarian insufficiency syndrome. Is that
Yes.
something different? It's not different, it's still fertility, but how is the psychology of
I
those,
think
how is
in
the care of those
patients,
patients?
I think in patients who experience this after a treatment, for example, a leukemia treatment, what we know there is that their fertility is gone. So they
Yeah,
don't have any fertility of their own anymore. Then it can be like a little light for them to know that they have their ovarian tissue or oocytes cryopreserved or sperm cells. But what we see there is the sometimes we see two types of fears in patients. Fear one is reintroducing the malignancy by
yeah,
transferring the tissue
the
into
tissue
the
back.
ovaries
Yeah,
again. But the second fear is also, will it be possible for me to have children in the future? And that's the most difficult one, because not me as a nurse, or neither my colleague Dr. De Vos, we can't answer the question because we don't know either. We can perform the transplantation, we can perform the IVF treatment, we can perform every treatment possible, but not me, not him, neither of us can conclude if it will be possible.
yeah,
So that's really difficult, the not knowing what will come. It's a bit a continue of the treatment, because in the treatment you also don't know what will come. Will I be okay again? Will I not be okay again? Will I have children? Won't I have children? That's a really difficult one. That's what we see in our patients, and that is the most difficult part of the fertility treatment, the not knowing if it will be possible, even though before the treatment I did everything that was possible at that
yeah.
moment.
It's like
Yeah.
you've had hope for the treatment
Yeah.
working, and yes, it
Mhm.
has. And then you've got hope that actually your fertility hasn't been overly affected,
Yeah,
and
and then what
oh,
I
it had
experienced
a
is really hard for
yeah,
me as a nurse, and maybe also for you as a nurse, to keep continuing to be the empathic one, holistic care, to keep saying, come on, let's do this, it will be all right. That's difficult for
Yeah.
me and for the patients, because sometimes I think we've had patients with a leukemia, they come back, we perform the transplantation, they need to perform an ICSI or an IVF 10, 15 times before they get pregnant. And then we need to say, oh, you can't lose hope because it will be all right.
yeah,
Maybe
Yeah.
that's difficult.
And it's quite difficult. It's quite easy, I think, for our patients who have, are exposed to such a lot of vulnerability to
Mhm.
become quite fixated on those uncertainties as well. And I think, particularly for, well, people who go through IVF in their normal life, not from insufficiency from chemotherapies,
Mhm.
it becomes a thing, doesn't it? It becomes that's the thing that's most prominent in their lives, and
Yeah, it's already
it
hard
can
for
be very
somebody who has a
challenging.
fertility issue.
Yeah,
Next to that, also the attachment of the oncological care.
yes,
It's like they get punished several times in their life
yeah,
because it has a lot of impact on a lot of parts of their life.
yeah. Now we're going to move on to the next section. Thanks so very much. And well, we have, we're going from challenges and difficulties and uncertainty to exciting development
yes.
and
Let's go to the
new
fun
things.
stuff.
So, so Iebe, just tell us a little bit about what's been happening in your unit, and
Mhm.
we're going to talk a little bit more about that new technique you referred
Mhm.
to before,
So at this
IVM. We're
moment,
going to
that's
hear a
what I
bit more
also
about
wanted to introduce. Thank you.
Hey, let's do it.
We are strongly developing and optimizing our IVM techniques. IVM is a great offer for potential fertility preservation patients, especially for the patients who cannot perform the golden standard hormonal stimulation due
Yeah,
to a lack of time before starting the oncological treatment. It includes the retrieving of the oocytes, the immature oocytes, and then we mature them in the lab in liquid. and then we can freeze them like a mature oocyte that you can use for an IVF or an ICSI treatment. So that's a great advantage. And next to that, I would also like to add that in December 2024, we performed the world's first testicular tissue transplantation
Cool.
in a boy with a desire to have children. It's a major milestone in the fertility care for oncological patients that have lost their fertility due to the medical induction of oncological treatments or stem cell transplantations. It is still an experiment. It was the first time. We didn't have somebody in the meantime, so it's really the first time, but it's an innovation. And we believe that it opens new doors to the restoring of the fertility for these patients. It's really important, I think.
Yeah, it's incredible. I think, that, and you mentioned earlier on, all we really need to do from a hematological perspective is to have a platelet count of over 50, and all the usual things of making sure we've been mindful to send off all of the virology screening so that a patient isn't slowed down at your end by needing to do any of that. It's incredible. We move to a time where there is now real opportunity for these patients to
Yes.
cryopreserve before treatment starts. So that's incredibly exciting. Do you know how many centers are doing this? Is it sort of very new and
This is very new. We were the world's first.
wow.
But I think in America that there are probably also some centers that are working on it.
Probably.
But in the whole world, we were the first to do the transplantation. So
Amazing.
really excited.
Congratulations.
A different kind of auto transplant, but very
Yes.
Yeah.
nonetheless. And this was written up, right? You shared with us a paper of
Uh,
various tissue auto transplantation.
mhm. Yes,
Do you want to share
this
that?
was on a patient who cryopreserved her ovarian tissue when she got leukemia, and afterwards she came back to us. We transplanted it, and we had to perform a lot of IVFs on her and a lot
Wow.
of treatments on her. But I think after the 14th time that she became pregnant, and in the meantime everything went well. She was the first woman in Europe to have the ovarian tissue transplantation an AML. So we were very excited that after all that it worked.
Oh,
And
that's
that she has a healthy
amazing.
boy right now.
Oh, that's so good.
And will she plan to have further children then,
I
using
don't
that
know
tissue,
because it
or is
was that was actually the patient my example of keep the hope up,
yeah,
be
Yeah.
strong. It was a
difficult?
really hard and difficult treatment
Yeah,
for her. We performed a lot of interventions. So
yeah,
she was always hopeful and she was always happy and she had like a really empowerment from her family, from us. So it was really nice to be supporting her and to be her nurse. But at the end we saw that it was enough, so I don't know if
yeah,
she has a desire to have a
Do
second.
you do you have like
yeah.
a maximum amount of times you would do ICSI or IVF, or is
We
that
always
not
in Belgium you have the reimbursement for 6 cycles, and
okay?
afterwards you need to
The
pay it
self-funding.
yourself.
Yeah, I wondered because
But
we've got
we
something
always
similar
try
and
to we
yeah,
try to discuss it with the patient, and also there, Dr. De Vos is a great support. He can also
yeah,
have a look on what the possibilities still are. So on that part, I trust him with my whole heart.
yeah.
But together we make it as a team. We discuss it with the patients. So it depends. It depends on what we see in the quality of the treatments as well.
That makes a lot of sense. Yeah.
Yeah, the case report is fantastic, and we're going to share the link of that online and wherever you get the pod from. So you can also read that. It really is amazing. And presumably your testicular tissue auto transplantation is also going to be written up, and
Probably it will.
yeah, that will be
Please,
available as
please
well.
write that
So
up.
yeah,
You have
that's
to write
fun.
that up. Bring it to another
So
EBMT conference.
yeah,
You.
yes, absolutely, yeah.
Yeah.
Yeah, and I think, you talked a little bit about some of the recommendations as well, I think, but do you want to just touch on those a bit as well?
Yeah, probably. Yeah. So the early referral, that's the most important, the open communication, and also the promoting of the shared decision making. I think that you as nurses can also be a great part of that to support the
Yeah.
patient. You can also make a little bit more of an idea of what the treatment of the patient will have as an impact on the rest of their life. So the shared decision making, the promotion to the fertility specialist, and the open communication. Don't be shy to talk about fertility, even though you know not a lot about it. You know the basics, so you know that you can that refer them to the centers. So even if you just tell that there is the possibility to do it, that's already a great advantage.
That's amazing. Gosh. I mean, I think you've mentioned a couple of cases, and we have the case in the paper. But I think you also mentioned, there are certain things that we need to ensure with our leukemia patients before they can go ahead with
Mhm.
the auto transplantation techniques or the IVF techniques after treatment. Do you want to talk a little bit about those and kind of explain a bit about cases and how, the
I think
considerations that you
it's
need?
certainly not the biggest part of my population, but what I see is that when we have young women or young men with a leukemia, before the treatment, you should consider with the hematologist if we have the time to start some treatment, and also what the blood work at that moment
Yeah,
is, because that's really important. What we see in young male patients, we can freeze the spermatozoids. It's no problem. Even if the leukemia is spread through the whole body, it's no problem. We can freeze it, so that's fine. And next to that, what we also see, unfortunately, in people or patients with a Hodgkin's lymphoma is that the quality of the ovocytes,
yeah,
it's really decreased.
yeah,
So they don't have a good quality of oocytes. So if they're really young, there we try to perform ovarian tissue cryopreservation and also the freezing of the oocytes. So the combined techniques.
yeah,
That's something that we do a lot of times. The combined techniques, which are also really important to increase the chances for the patient afterwards. But I think for you, what's the most important is the discussion with the treating doctor, if they are okay that we still perform something. Do we need to start the treatment already? Do we have to wait until there is a remission, more stable state of life at that moment? So it's really depending on the multidisciplinary care. It's really important for the
yeah.
oncofertility patients.
You mentioned about Hodgkin's lymphoma. Do we know why that is that the disease
There are
has
some studies that are done about this. I should check it once more because I did not prepare it.
yeah,
Yeah.
no,
But
I confess I don't know
it's
either.
something that we see.
Yeah.
It's yeah, we
It's
see
well known.
almost
Yeah,
all
yeah,
the
it's well known.
patients.
Yeah, yeah, yeah. Amazing. Gosh, well, we're almost at the end of the pod, and I don't know, Emma, if you had in anything else that you wanted to ask Iebe
I
before
want to tell so
uh,
much more, but I don't have the time.
before we hear Ibe's takeaway message.
Well, that's it. Yeah. What's
My
your takeaway
takeaway
message?
message is that fertility preservation is complex, it's multidisciplinary, and it's also important to communicate very clear with the patient. You need to perform the emotional support for the patient. It's really essential. We do a lot in the fertility centers to improve the chances of all the patients that come to us, because we want to give them the best care. We only have a single shot in those patients. We can't make mistakes with them. But we have maybe to conclude that it's an uncertain journey for all the patients who come and visit me before and after the treatment.
Yeah. That's amazing. I think your patients are very fortunate to have you, Iebe. I think it's been an absolute pleasure to talk to you. I think you mentioned quite a few different cryopreservation techniques, and we'll have
Mhm.
some links on the sites for people who want to read a little bit more, as well as that landmark case that you had for the auto
Yes.
transplantation. I think that leaves us now just to close the pod and say a huge thank you to you for joining us. And thank you very much, Emma, for
Oh, thanks.
co-hosting.
Thank you for
It's
having
really
me. It
good
was a
one.
great pleasure to explain it.
Oh, we
Thanks
love
so
it. I
much.
think we're gonna need to take this conversation a lot further in our probably our own little areas. I certainly will be taking this back to
Mhm.
my centres and say, look
We're
what they're
going
doing, look what Eva's doing. Let's
Yeah.
go.
And we do have another pod plan to look at
We do.
fertility cryopreservation for pediatrics for
Mhm.
children, which is actually probably some of the similar techniques, but the environment within which
Yes,
that happens
exactly. Mhm.
is very different. And we need to make that distinction. I think there's a very good education there. Thanks so much once again. Thank you.
Thank you.
Thanks,
Bye.
Bye.
guys. Bye. We're really interested to hear your thoughts on the topic that we covered in this podcast. What would you add from your own experience? You can reach out to us via email through the EBMT website or just leave a comment on YouTube or Spotify where you found our podcast. Don't forget to check out the resources that we mentioned in this episode. Thank you so much for joining us, and until next time.